Thank you to JSES, and good afternoon, everyone. I'm Shibao from UH Hospital in Japan. It's great pleasure for me to be invited to such a prestigious session. I really appreciate all participants. My topic today is function-preserving gastrectomy for early gastric cancer. I have no COI. So this slide includes narration, so please sound on.
And the loss of these functions lead to various symptoms. That's why we try to preserve the function of the stomach.
Let me see. Okay, again.
There are functions of the stomach, including capacity absorption and hormone secretion. And the loss of these functions leads to various symptoms. That's why we try to preserve the function of the stomach. Pylorus-preserving gastrectomy, PPG, and proximal gastrectomy, PG, are representative function preserving gastrectomy. During PPG, about half of the central part is resected, and the cardia and pylorus are preserved. For PG by proximal gastrectomy, about one-third of the proximal part with cardia is resected. This procedure avoids total gastrectomy, while reflux esophagitis should be prevented after reconstruction with some additional treatment. So, I don't think it has to be an extensive resection for all cases to preserve function. What are good indications for functional preserving gastrectomy? Early cancer, which shows shallow depth up to the submucosal layer, usually has a low possibility of lymph node metastasis by preoperative CD. The essential points of function-preserving gastrectomy are as follows. The resection area of the stomach and the lymph node is reduced. Early cancer with a low possibility of lymph node metastasis adopt function-preserving gastrectomy. A more accurate and preoperative diagnosis is required. So, PZ for upper gastric cancer and PPZ for middle gastric cancer represent function-preserving gastrectomy and their today's topics. So, the first topic is PPZ, Pylorus-preserving gastrectomy. PPZ would be indicated to early gastric cancer in the middle stomach and 4 cm or more apart from the pylorus ring. Exclusion criteria are a small remnant stomach and a preoperative GERD case. Several articles reported the advantages of PPZ, including fever dampening syndrome, diarrhea, good nutritional status, and blood sugar fluctuations compared with conventional distal gastrectomy. PPZ also shows a good survival like this. PPZ has achieved comparable 5-year survival rate to DZ, while also aiming to maintain the patient's post-operative quality of life by reducing the extent of lymphadenectomy and gastric resection without compromising long-term prognosis. There are some problems after PPZ, stasis, and reflux. The rate of stasis was up to 23%, and risk factors were age, diabetes, and infection after surgery. The rate of reflux was high, 15%. The risk factors for the reflux are a male patient, preoperative grade A reflux, postoperative body weight loss, BMI loss, hernia formation, and stasis. The next topic is function-preserving gastrectomy for upper gastric cancer. The number of upper gastric cancer has increased up to 1/4 of all cases in the 2010s from 3.7% in the 1940s data. So, there are three procedures for upper gastric cancer: total gastrectomy, PZ, and subtotal gastrectomy. PZ would be performed as a functional preserving gastrectomy for upper gastric cancer. This pie chart shows the surgical procedures for upper gastric cancer in Japan. About 30% of upper gastric cancer patients have received PZ. This slide shows the indications for proximal gastrectomy. A half or more remnant stomach inside would be preferable. The advantages of proximal gastrectomy are less diarrhea, dumping syndrome, less iron, and vitamin B12 deficiency. Indeed, there are several meta-analyses of PZ and TZ for proximal gastric cancer. They reported that the PZ was superior in terms of post-operative nutrition status compared with total gastrectomy without compromising the long-term prognosis. There are two types of reconstruction methods after PZ: esophagogastrostomy and the use of the small intestine. This pie chart shows the reconstruction methods following PZ in Japan. Esophagogastrostomy is a preferred method of many surgeons in Japan in the physiologic pathway. Double tract is also chosen for reconstruction by many Japanese surgeons. The double track method reduces reflux, but can sometimes make it hard for food to enter the stomach properly. However, simple esophagogastrostomy frequently develops severe reflux. Thus, EZ is usually accomplished with anti-reflux techniques, including DFT, pseudophonics, fan application, and side overlap. This pie chart shows the reconstruction method with anti-reflux procedures. The double flap technique is currently a preferred reconstruction technique in Japan. However, standardized reconstruction methods after PZ have yet to be established. We mainly chose the double flap technique, but applied the side overlap in case of intrathoracic anosmosis. As for DFT, DFT pushes up the anosmotic site by pseudophonics contents. The anosmotic site works like a valve, so the anosmosis is not left open, as it would be without a valve like this. This mechanism prevents a backflow from the stomach. I'll show you a video demonstrating the effectiveness of the DFT in preventing esophageal reflux after the surgery. After ingesting contrast material, our patient was placed in right lateral recumbency and treated to a 15-degree head-down position. The absence of reflux to the esophagus demonstrates a strong reflux protective effect. We reported that the DFT technique resulted in less post-operative weight loss than total gastrectomy. Additionally, in the TZ group, every patient experienced weight loss 1 year after their surgery. In contrast, in the PZ group, 13.1% of patients successfully maintained weight. However, post-operative structure is often a problem. A structure rate of 4.7% to 29.1% was reported. Risk factors for stenosis after DFT are esophagus size of less than 18 millimeters and short-term complications. However, we have experienced no anastomotic structure in our series. Making wide anastomosis may be a key to preventing stricture. In summary, function-preserving gastrectomy is a suitable option for early gastric cancer. PPZ and PZ are representative procedures. The choice of procedure should be based on a precise preoperative diagnosis. Before proceeding, a thorough understanding of each method's benefits and risks is essential. There are
Sorry. Before closing my talk, I'd like to share a personal milestone with you. My dream came true. I completed the Boston Marathon 3 days ago, just before the conference. And the cheering on the street was the most amazing I have ever experienced. And please, let's see. Please watch this video. You see, it was unforgettable memory for me. And I also ran in the morning with Seiji's friends. It was another unforgettable memory for me. Thank you for your kind attention. Thank you.